Our last speaker this morning is Dr. Tom Harrison, who comes from the University, from St. George's, the University of London, and we'll see how our time is. We may just go directly into the break after he speaks, and then we'll look at a couple questions afterwards. But Dr. Harrison is going to speak on the clinical trials in Cryptococcus, and has really been inspirational in sort of doing a series of well thought out phase 2 studies that have led to some now phase 3 trials, which I imagine we're going to hear about.
Okay, thank you very much, David. So I'm going to give you a clinical perspective on cryptococcal meningitis from the setting of from the resource-limited setting and HIV-associated disease. I'm going to touch on the epidemiology, some current issues in treatment and prevention. So in terms of the epidemiology, I think in terms of the epidemiology, I suggest we're going to be moving from the era of Park et al. To the era of Rajasingham et al. Because there's a much-needed update in our estimate of the global burden of HIV-associated cryptococcal meningitis in progress, and then give you just a little bit extra on-the-ground, if you like, data about the ongoing burden of cases in sub-Saharan Africa. In terms of treatment, something about recent and ongoing antifungal trials, the need for new drugs. I don't have time to talk about CSF pressure management and the issue of the best timing of antiretroviral therapy and ARIS, but perhaps just in very quick summary to say, I think the evidence is fairly overwhelming now for the efficacy of therapeutic lumbar punctures and the importance of measuring and managing high CSF pressure in HIV-associated meningitis. And in terms of the timing of antiretroviral therapy, of course, David Boulware and his colleagues showed us very clearly in the COAT study that starting at 8 days was too early. So our current recommendation is 4 to 6 weeks. And I think we would favor 4 weeks rather than 6 weeks, but these issues we can discuss later if there's time. And then at the end talk about, as Sharon mentioned, an update on the screening and preemptive treatment strategy to try and actually prevent some clinical cases from developing in the first place. So what about the HIV-associated disease epidemiology? You can't talk about this without referring to Ben Park and the CDC's group's landmark study. But this was based on available incidence data at that time. And of course, the total number of HIV deaths in the world has decreased from the 2000s to the current time, thank goodness. So these were point estimates. The often quoted headline was 500,000 deaths per year, but there were wide confidence intervals. In the current update in terms of the global burden that David Boulware has been leading with CDC colleagues, with Tom Chiller, with Ben Park, incidentally, and Rajasingham, is based on a different approach about the numbers of patients at risk, estimates of the number of patients living with HIV, the proportion with a low CD4 count, and quite a body of evidence now we have about the CRAG prevalence data from different populations. So the cases and the point estimates for the deaths are lower than with the Park study, but actually within the confidence intervals of the Park study, about 140,000 deaths per year. And some of these proportions, though, haven't changed. Roughly 17% of AIDS-related mortality. And of course, the great burden of disease remains in sub-Saharan Africa, where again, the best estimate in terms of case fatality rate remains around 70% 3-month mortality. So there are some things which clearly haven't changed. And I'm grateful to David and Radha for giving me these just couple of slides to show this is the geographic breakdown. Of course, the predominance of the burden of disease in sub-Saharan Africa continues, and this nice global map reminding us that the burden of crypto is so high in southern and eastern Africa, but also that some populous countries like Nigeria and India, in terms of just the numbers of cases, are an important contributor to the global burden. So the fact is, I haven't yet seen any convincing data from outside of South Africa, in sub-Saharan Africa, of any decrease in cases, despite the fact that antiretroviral therapy, access to antiretroviral therapy has clearly made massive strides forward. The total cases of crypto haven't changed, but now what we're consistently seeing is that over half of the patients have actually had antiretroviral therapy in the past. This comes from our enrollment data with our ongoing phase 3 ACTA trial, but it's also clearly there in the recent published studies. The Crypto-DEX study by Jeremy Day and colleagues recently published, and in Josh Ryan and David Bulwer's group, the phase 2 Sertraline study. Half of patients have met antiretroviral therapy, but they have persisting low CD4 counts, predominantly due to the fact that these patients have been lost from care and are no longer taking antiretroviral therapy, I would say more than frank antiretroviral resistance. In addition to this data, Joe Jarvis has got, working in Botswana, very valuable epidemiological data that he's recently presented at the AIDS meeting in Durban, showing that actually in Botswana, despite the fact they have a well-developed antiretroviral program, it's not the poorest country in Africa by any means. In fact, in recent years, the cases are actually increasing, as he's shown, because of the fact that the absolute numbers of patients with a low CD4 count is rising due to cumulative default from care. So the challenge used to be in HIV, keeping up with the epidemic, the number of patients progressing to late-stage disease prior to being diagnosed and treatment. Prior to being diagnosed and getting on treatment. But I think, you know, the evidence is mounting that the overwhelming challenge now is retention of the patients in care once they start ARVs. This is Joe's data from Botswana that he presented in Durban. This is in terms over the years of the percentage of CSFs which were crypto positive, but it's the same in terms of the trends in numbers and his conclusion about the ongoing burden. And you only have to look at our trial recruitment in our studies and in David Bulwer's group and Jeremy Day's studies as well. You only have to look at the recruitment rates. This is our ACTA trial. We haven't had any problem, unfortunately, recruiting patients over the last years. And this is in the Ambition trial, and I've got some slides about these ongoing trials. And if you look at the published phase 2 Astro study with sertraline adjunctive therapy, 225 patients seen at Mulago Hospital in 1 year. So the cases, unfortunately, are not yet decreasing. And of course, in terms of the cause of adult meningitis in southern and eastern Africa, crypto is just simply the predominant cause. What about recent outcome data? I think we have to be somewhat humble about this, that we haven't as yet made a huge impact. And the best outcomes in general are, of course, in clinical trial settings with our current gold standard of 2 weeks amphotericin-based treatment is, roughly speaking, 35 to 40% 10-week mortality. This is from our own combined cohort data, combined phase 2 studies, but the very similar number from the steroid study in the non-steroid arm, similar number from the sertraline phase 2 study. This is the best currently. The usual reality, of course, is not as good as that, and with fluconazole monotherapy that remains the standard of care across most of sub-Saharan Africa, the fact is that patients keep on dying, so that by 1 year, it's only less than a quarter of patients who have survived in this cohort study of fluconazole monotherapy. And on top of that, even with amphotericin B in routine care, because of the challenges of delivering 2 weeks of amphotericin B-based therapy in sub-Saharan Africa, in fact, the outcomes in routine care don't look a whole lot better than with fluconazole. This is a study from Zambia with 39% in-hospital mortality, and this is Nilesh Govenda's data from surveillance in South Africa. Despite the fact that the use of amphotericin B has increased, the case fatality rate, the inpatient death rate, has remained static around the 35% mark. And of course, 35 to 39% in-hospital mortality converts to well over 50% 10-week mortality. So that's, you know, the ongoing burden of HIV-associated cryptococcal meningitis in sub-Saharan Africa. What about treatment? And of course, our gold standard for treatment internationally has remained for some years now, the Amphotericin B and flucytosine. And it was based, of course, on the mycosis study group landmark study of Charlie Vanderhorst, published 9 years ago now in the New England Journal, supported by our own work showing that that combination was the most rapidly fungicidal, but really nailed by the Vietnam study conducted by Jeremy Day and colleagues, published more recently. And I'll just make one point about that study, which is, and this shows the survival curves from the Vietnam trial. This is ANFO plus flucytosine, ANFO plus fluconazole, and ANFO alone. Just to point out that actually the difference here between ANFO and flucytosine and ANFO alone is a very significant difference. This wasn't a huge study. It was only powered to detect a pretty large effect, and that's what it did detect. This is a 40% reduction rate in mortality rate at 10 weeks. And I'd put it to you that that's a very significant advantage. The issue, however, of course, is that as we've seen, giving 2 weeks of amphotericin-based combination therapy in Africa is simply not available or feasible in most centers, whereas the fluconazole alternative, which is available, is inferior. So this is where the ongoing trials come in, and the aims of the ASTRO trial, the ACTA trial, and the AMBITION trial that I'll just discuss very briefly. And of course, David and Josh and others from their team can comment in the discussion time and speak much more to the Sertraline studies, but they have studied Sertraline as an affordable, available, safe adjunct with antifungal activity and published a phase 2 study recently in Lancet Infectious Diseases. In a dose-ranging study, they found that the sertraline given in addition to ANFO and fluconazole, the combined EFA in the sertraline arms was more rapid than historical controls treated with the same backbone at the same sites. And of course, a phase 3 study that we'll be very interested to see the results of is currently underway. In terms of the ACTA trial, this is a phase 3 trial going on in 4 countries in sub-Saharan Africa. And it's built on a series of phase 2 studies that we did over a number of years, 2007 to 12, to define regimens that are more rapidly fungicidal than fluconazole monotherapy and as active as 2 weeks amphotericin B, but more sustainable in resource-limited settings. So the strategies we're testing in ACTA are, number 1, high-dose fluconazole plus flucytosine, and number 2, and I'll show you the data to support that very briefly, number 2, shortened amphotericin B-based combination therapy for just 1 week, shortened induction treatment, compared to the aspirational gold standard in these settings of the standard 2-week amphotericin B-based combination treatment. And as you see, we're also taking advantage of this study to compare again fluconazole with flucytosine in the 2 amphotericin B arms, because that comparison remains of such critical importance for Africa, where currently fluconazole is available, but currently flucytosine isn't. And I emphasize the word currently. So just to give you very briefly the data that supports the phase 2 studies that support the ACTA arms, this is a randomized control phase 2 study showing that with high-dose fluconazole and flucytosine, we can get rates of clearance which are virtually the same as we'd measured originally in the original EFA study that we did in Thailand with the amphotericin B alone arm. And as you might expect with that increased clearance rate, the combination showed improved survival over fluconazole monotherapy, even though it was a small phase 2 study not powered for clinical endpoints. And in terms of the short course amphotericin B induction, just to make, we studied this in Uganda and Malawi as well as originally in Cape Town. What we always noticed when we gave the shorter courses of amphotericin B, and this cohort from Uganda was treated with just 5 days amphotericin B, was that even though the ANFO had been stopped here, the rate of clearance continued and there was no plateauing of that effect. In other words, it appeared that we were having prolonged efficacy with the Amphotericin B treatment, probably because of the long half-life of the drug, especially perhaps in brain tissue. And of course, we gained on tolerability hugely because the clinical side effects of Amphotericin B tend to come in the second week, and hugely as well in terms of sustainability and cost and feasibility in Africa. And subsequently, the short course ANFO also received some support from these preclinical studies done actually after the clinical studies by William Hope's group in Liverpool, where he does careful PK/PD modeling in both the murine and the rabbit models. And he showed that in both those models, in terms of the CFU count at 14 days, then there were similar results whether you dosed the ANFO daily over the whole 14 days or gave an initial 3-day abbreviated course. Again, speaking to the fact that perhaps if you load up the brain compartments early, then you get a prolonged antifungal effect. So this is the ACTA trial. It's been conducted in 4 countries, in 9 hospitals, 2 funders. Plenty of people to upset if we're not careful, but I'm pleased to say that we have now almost completed this study. We've enrolled 690 patients. We're hoping to finish the study before the end of this year. I don't know, of course, being the investigator, the results, but we are hopeful, given that the DMC has met the Data and Safety Monitoring Committee on about 8 occasions now and have not stopped any arm of this trial, that one or other of our experimental strategies must be performing reasonably well. And of course, the potential impact, if either of the experimental strategies were shown to be as effective as 2 weeks amphotericin B induction, would be that in resource-limited settings, which are currently using fluconazole with mortalities of around 70%, the mortalities could be reduced to 35 to the 40% level seen with 2-week amphotericin B combination treatment. If not, if the trial doesn't work, then of course we need to learn to safely deliver 2 weeks amphotericin B or learn how to use the alternative formulation of ambisome, as I'll come on to mention. So the second trial that we're currently involved in is called the Ambition trial, and it is ambisome, liposomal amphotericin B. In prior trials, it's been hard to show that it's more effective than conventional deoxycholate, but it's clearly less toxic with less renal impairment and anemia. And it's also got a long half-life and excellent brain levels. So even better than conventional drug, it may be better suited to a short course, high-dose induction strategy aimed at quickly loading the brain compartments. And in fact, of course, there's well-known precedent for such use of ambisome in visceral leishmaniasis from the work of Syam Sundar in Varanasi in India, where he published that just 1 10 milligram per kilogram dose was effective in visceral leishmaniasis. And of course, if 1 or a few doses were effective, it could actually be cost-effective due to the shorter admission, the less side effects and less need for monitoring, and it could be a feasible strategy to implement. So that's the New England Journal of Medicine from about visceral leishmaniasis. This, of course, was the basis of a Gilead Global Access program, which made ambisome available at reduced cost for visceral leishmaniasis. And of course, we're hopeful that that program could be extended to cryptococcal meningitis if the data were supportive. This is some PK data about using a high-dose loading strategy, high intermittent doses of ambisome from, again, William Hope and David Stevens, looking at the PK data with conventional daily dosing versus giving a high dose and then 2 backup doses. And this was the type of strategy that we used in the phase 2 Ambition study that Joe Jarvis has been leading out of Botswana, and we're also been recruiting patients in Tanzania. So there have been 4 arms in this study, and giving all on a background of high-dose fluconazole at 1,200 milligrams a day, 1 dose of ambisome, 10 milligram per kilogram on day 1, the same dose plus another one at day 3 of 5 milligrams, or a 10-5-5 at day 3 and day 7, compared to conventional daily dosing of ambisome over the first 14 days. So, and the plan is to use the clearance data, the early fungicidal activity data, as the endpoint in this phase 2 study to determine the shortest course of ambisome that it will be non-inferior to usual daily dosing. Also, of course, take into account any of the clinical endpoint and safety data from the phase 2 study, and choose the best short regimen to take forward to a phase 3 comparison with the current international gold standard of daily conventional Amphotericin B deoxycholate. And we plan to review the data after 80 patients. And I can say that we have reached, as you'll see here, the 80 patient mark, and the review of the data is underway, and I hope we'll be able to present that data in the not too distant future. But the good thing to note is that we have already got the funding for the phase 3 study to take the study forward to phase 3 with the chosen ambisome arm. This funded by the EDCTP with support from the UK MRC, which we hope to start in early next year. So in addition to those ongoing trial efforts with existing drugs, of course we do need increasing access to those existing drugs and the diagnostics and the manometers. And many of you will be aware of the work of the CryptoMag advocacy group led by the CDC and Angela Lois from George's, including all major stakeholders. And for me, the priority for that group is access to flucytosine. It is coming. I do believe that we will have flucytosine in the not too distant future. We know that major generics are making this drug, and the latest we heard was that they would be available by the end of next year. But of course, we also need new drugs, especially oral cidal drugs that don't interact with HIV or TB treatment and that synergize with our current drugs. And the Viamet drug 1129 is certainly one new compound that is promising for cryptococcal treatment, being specifically developed for that, and is potentially such a drug. Promising preclinical data and just starting into clinical evaluation. In addition, though, there are other avenues, including oral Amphotericin B formulations, for which preclinical work is ongoing. And in addition to the Sertraline, in terms of repurposing drugs, there's ongoing work around tamoxifen and benzimidazoles, which are known to have anti-cryptococcal activity. For those of you interested in the Viamet product, you can get an update from their website about the preclinical data that's been published about 1129. But Viamet also have another series of compounds, and I think we might be hearing more about their drugs later in the meeting. So I want to finish up by updating you, as Sharon mentioned, about the screening and preemptive treatment strategy to try and prevent some of this burden of HIV-related cryptococcal disease. And of course, the rationale here is that in Africa in particular, many patients simply come too late for antifungal treatment to be effective. The headache at the beginning is non-specific. Traditionally, diagnosis has been by lumbar puncture. However, most of these patients, as I've already mentioned, are already known to the health services. Many of them are already have seen ART. So many of these cases should be preventable through the early subclinical diagnosis of cryptococcal infection using the IMI dipstick point of care lateral flow CRAG assay. Because, as you know, we know that CRAG is shed in blood as well as urine and CSF very early in infection, even prior to symptoms. So late-stage patients can be screened for CRAG. The 4 to 8% or whoever who screen positive are then preemptively treated with antifungal, which is currently fluconazole, prior to antiretroviral therapy. So that's a strategy. It was based on several studies, including this retrospective study from Joe Jarvis from Cape Town that clearly showed that the screening identified the patients at risk in quite a large cohort of patients. The samples tested retrospectively. Patients who tested negative didn't get meningitis. Those who tested positive had a very high chance of getting meningitis. And then all the modeling that Sharon's mentioned that showed that it should be highly cost-effective, indeed cost-saving, as well as saving lives, saving the costs of later admissions. So the CDC have really led in the promotion of the strategy. The data have been enough for WHO, South Africa to roll out programs, MSF and others. But we didn't, until relatively recently, actually have prospective data. But we do now have quite a body of prospective data that's coming out on screening. We have the South African program from Nelesh and colleagues. We have a Nikki Longley study, a prospective single-site study from Cape Town. We have the REMSTART and the AUKUS trials, and also experience from Tanzania. And for me, there are some messages which seem to be some common themes which are coming out of these studies. And I've put some conclusions here, and then I'll justify them with the last few slides. First of all, I think the evidence is that screening and preemptive fluconazole almost certainly does save lives. But the body of evidence suggests that the CRAG-positive patients still have an ongoing higher mortality than those testing CRAG-negative. Furthermore, a significant proportion of CRAG-positive patients, even though they're not symptomatic, if they agree to an LP, they have evidence of subclinical meningitis in that they have a CSF CRAG positive, and somewhere in the region of 30 to 40% of all patients with a blood CRAG positive test. In addition, a high blood titer, perhaps not surprisingly, seems to predict subclinical meningitis, and a high blood titer of cryptococcal antigen and the subclinical meningitis are both associated with higher mortality. So for me, the inference of this data is that we need to study more effective antifungal therapy for CRAG-positive patients, especially perhaps those with high titer, of course, in the context of a bundle of other diagnostics for opportunistic infections and adherence, ART adherence support for all patients. So what about the data supporting some of those statements in the last slide? This is just a bit about the REMSTART study that was conducted in Tanzania and in Zambia, led by Dr. Mfinanga and Shaba Jaffa. Again here, newly diagnosed patients with a low CD4 count, having either the standard of care or else CRAG screening along the lines I've mentioned with fluconazole for those testing positive, plus a second intervention, which was ART adherence support. Lay workers visited the patients at home once a week for the first month of ART therapy. All the patients got counseling and rapid initiation of antiretroviral therapy at 14 days. They all got modern TB diagnostics, and the primary endpoint was all-cause mortality at 12 months. So around about 1,000 patients were enrolled in this study between 2012 and 2013. And this shows you the results of the study published last year in The Lancet. And the result was that the intervention arm, which included the CRAG screening, the mortality rate was 28% lower than in the standard of care arm. The CRAG positivity rate was around 4%, so in line with prior studies. So the immediate question was, well, how much was that due to CRAG screening? How much was due to ART adherence? And you can make some guesswork about that based on estimates of what proportion of CRAG positives in the control unscreened arm you think would have died not having had any fluconazole therapy. The long and the short of it is we thought that about half of this effect was due to the CRAG screening and half was due to the adherence support. So, but as I say, in the REMSTART study, still, despite fluconazole, CRAG-positive patients had a mortality of about 30% compared with 13 in the CRAG-negative arm. It's very similar, the experience from Cape Town and the data coming out of Nelesh's program from Johannesburg. There appears to be this ongoing residual, if you like, high mortality of the CRAG-positive patients. Here's the evidence about the subclinical meningitis. This is Nikki Longley's data from Cape Town. This is the spread of antigen titers in the CRAG-positive patients, and this is 10 patients agreeing to lumbar puncture, and those with the CSF CRAG-positive are the ones with the high titer above 1 to 160. And that 40% is mirrored, as I said, in the Johannesburg data and the Tanzanian experience, which were both presented in this recent meeting we had, AIDS mycosis meeting in Cape Town. And sorry, this shows you the Johannesburg data that Nelesh and Rachel Wake presented in Cape Town. Again, looks like a cutoff of around 1 and 160 is a reasonable one for predicting CSF CRAG positivity. So The titer, is, as well as being associated with subclinical meningitis, is also associated with mortality. David Boulware's group clearly showed that from the AUKUS study presented at CROI earlier this year. Again, the same sort of cutoff. What is so far a little less clear is the exact causes of death in the CRAG-positive patients. In the REMSTART study, for what it's worth, the verbal autopsy data suggested most deaths were still due to crypto. In Nicky Longley's study, we thought most of the deaths, although it's a small number, were not directly due to crypto. And again, in Johannesburg, 6 out of 10 of the deaths were thought clinically to be cryptococcal meningitis. And the thing different that Rachel Wake is doing with Nelesh in Johannesburg in her study is doing some limited post-mortems on the patients who die. And although it's still anecdotal, I think it's intriguing that in a number of patients, she has found patients who, at the time of screening, had had a lumbar puncture and been CSF CRAG negative, been treated with fluconazole, but who've later died, and then at post-mortem been found to be CSF CRAG positive. So for me, as I say, the body of evidence suggests that many of these CRAG-positive patients may benefit from more effective antifungal therapy, especially those at high titer. And many of you will be aware that we will be able to rapidly assess whether patients have high or low titer through new semi-quantitative CRAG tests that are coming in both from IMI and from Biosinex. So perhaps one way forward is to look at a combination of fluconazole and flucytosine for CRAG-positive patients. We know this is a safe and much more effective treatment than fluconazole alone, and it could be a feasible and sustainable oral option for more effective therapy for CRAG-positive patients. So we have an ongoing effort, a wide consortium with Shaba Jaffa, Nelesh, Dr. Finanga, and the group from Tanzania, Joe and David Boulware and the Uganda group, as well as ourselves, to try and get funding for this refined study to be conducted across sites in Africa. Obviously, to do a randomized study of screening, you need a large number of centers to randomize CRAG-positive patients to fluconazole and flucytosine. In the analysis, explore if there's a cutoff at which the combination is clearly needed, which could, of course, be targeted by semi-quantitative tests. But in addition, embed this in measures to support these late-stage patients with additional measures in terms of the latest diagnostics for other OIs, particularly, of course, TB, and adherence support. So I will finish there and just acknowledge, of course, our particular collaborators. We have many collaborators across Africa, but I've just singled out a few of them there. And just to acknowledge that for a study like the ACTA study, it's an awful lot of work from an awful lot of people. And that's not an exhaustive list. So thank you.